it's no longer possible for me to get my fingers on the facet joints to feel how much is the facet joint actually moving. We could do that at the neck. So what we're doing is we're kind of doing a very indirect assessment here, but it's the best we've got. If they're not separating well, they're separating too little, one reason for that could be capsular restriction. But what else could it be? Could be muscle guarding or any soft tissue tightness or restrictions that exist. Postural changes to soft tissues in and around the neck. And then if I'm going to do flexion, I'm just going to ask you, Darius, just try to relax as best you can. And I am going to feel for how much opening happens between those two spinous processes. Once I feel like that vertebrae doesn't move anymore, and the next one's about to go, I want to keep that head there and just move my finger down 1 intraspinous space and assess from there and start to feel how much is that moving? Too much, too little, or just right? Once I feel like I've got a good assessment of that and that superior vertebrae is not going to move anymore, I go down next. Can move down to T3, T4. This is typically where this is going to start stopping. And now I can start to look at backward bending. Okay, backward bending, you're just trying to feel when do they approximate each other. Except now I can do rotation to the right. And what I'm feeling for, what I'm trying to feel for is the movement of the spinous process. So when I turn his head to the right, the spinous process should move to the left. So I'm feeling for how much does that spinous process move left. Once I've identified that's how much motion they have at that segment, I can go down to the next one. Finger method. All right. And what you're going to do with each of those fingers is you are going to locate the transverse processes of the vertebrae that you are interested in assessing. It's going to be for middle thoracic down. We don't want to be doing this method in the upper thoracic spine, okay? So I'm on T5, and my fingers, I'm going to locate the transverse processes of T5. And then what I'm going to do is just for my wrist, you can all see how my wrist is extended, not very good mechanics. What you want to do is place your arm nice and flat on the person. So the wrist is neutral, and these fingers are generally, and this hand is very relaxed. You're going to come over the top of your two fingers with your other hand, and through the fifth metacarpal, the hypothenar side, and you're just going to impart a posterior to anterior force. And you are going to try to feel for how much do your fingers go down with the transverse process. So when my fingers are on T5, I'm assessing a flexion on T5 on T6. I need to move down. I need to locate where the next transverse processes are. Once I'm as confident as I can be that I'm on them, I do the same procedure. Now I'm assessing T6 on T7. And you just count your way down. You can do this procedure all the way down to T12. Lower vertebrae, like 10, 11, 12. When we get to lumbar, the person's going to be sidelined, and instead of moving it top down, we're going to be moving it bottom up. But we'll get to that when you get to lumbar. Right. For rotation, the two fingers are no longer going to be on the same vertebrae. Transverse process of one vertebrae and the transverse process of the one below it on the opposite side. So in this case, if my third digit is on the transverse, the right transverse, third finger is on the right transverse process of T6. My index finger is now on the left transverse process of T7. Now what I'm going to do is the exact same thing I did a moment ago, except now instead of my hand being straight across, they're at an angle. And I'm going to do the exact same motion and get an assessment for when the right one goes forward and the left one goes forward, how much are those two rotating on each other? So here's T6, here's T7, the person's laying down. For T6, I'm on the right-hand side pushing it down. And for T8, the next one down, I'm on the left-hand side turning it down. So what rotation am I measuring in this person? Right or left rotation? Left. Left rotation. If I'm on T6 on the right and T7 on the left, which way is T6 going to turn? To the person's left or to their right? To the left. And motion is always named what on top is do it in comparison to underneath. To assess right rotation, I need to orient my fingers in the opposite direction. We call that the rule of the inferior finger or the lower finger or something like that. It's whichever side the finger is down, that's the rotation you are assessing. That finger's lower down, I'm assessing left rotation all the way down the line, one after the other. Once I've assessed all that, I'll come back to the top and just reorient my fingers the opposite way. And now I'm assessing right rotation because my lower finger is on the right-hand side. I'm pushing one way and I'm pushing the other one the opposite way. And then what the ultimate rotation is what does the top one look like in regard to the one underneath it? That's very important. Forward bending is designed to measure forward bending only. Always keep in mind that if I am on the transverse processes of T7, and I am doing this, pressing down, I am forward bending T7 on T8, but what's happening between T6 and T7? Extension, backward bend. So it is possible, especially for individuals with facet syndromes, and we'll talk about facets in a little bit, that when you get to that lower vertebrae, sometimes that can really hurt because you've got that upgliding going on there. Assessment is a central PA. So all you're going to do there is you are going to get on the spinous process, so starting at T5. All you've got to do is press on that spinous process. Because they're pointed so downward, right? Remember the spinous processes in the thoracic spine, especially as we get to the middle thoracic spine, they point down quite a bit. That when I get on that spinous process and I push it straight down, the vertebrae underneath it is going to do that. And on T6, when I press on the spinous process of T5, it is extending, it's backward bending. So that's why the assessment for backward bending that you want to do is the central PA. So you're just going to get on the spinous process, you're going to do that pulse T5, you're assessing T5 on T6. If you're on T6, you're assessing 6 on 7. Pages 263 to 264 in your textbook, hint, hint. Assess if the person is hypo, hyper, or if it produces symptoms. In many individuals, this central PA can be very irritating, especially if the pain and dysfunction is coming from the vertebrae or maybe even the ribs. This can be more painful if it's coming from the vertebrae. Unilateral PAs can be performed to assess unilateral mobility and symptom production. I can always do my unilateral PAs, where I'm going to get on one side, I'm going to get on the transverse process on the one side and use a dummy thumb technique. So for the upper thoracic spine, T1, 2, 3, 4, you should stand at the head of the bed to do that. Okay. As you get lower down, you should come to the side of the bed and just do your dummy thumb techniques that way. So for the upper ribs, and so really ribs like 1 through 6 or so, and we're not really going to get like 1, 2, but really we're looking like 3, 4, 4, 5, 6. And it is a pump handle motion. So the motion I'm looking for is how well do the ribs elevate up this way, right? That's what I'm kind of feeling for. And you can see as I'm flexing his arm overhead, his ribs want to come up and separate with that. So as an assessment, what you want to do into that space, and then I'm going to start to flex the arm until I start to feel that motion between there. So that can be done with 2 fingers like that. What other texts I show is just kind of your finger in between, so that it's in between the ribs, okay, like in the intercostal space. And feel for how much of those ribs separated. And you're just going to do this down to about rib 5 or 6, or until you feel like, I don't feel like I'm feeling the ribs move so much anymore. And then you're going to change to the bucket handle. Later on, from a mobility standpoint, if we decide we need to mobilize that, we're just going to stabilize and then do our mobilization technique. So the bucket handle technique, and with abducting the arm, the ribs should move this way, which is that bucket handle. And then what I'm going to do is, instead of flexion, what I really want to think about is abducting the arm. And then what I'm going to do is I'm going to find that rib space that I want to assess, get my hand in there, and then I can start to assess for how much are those ribs separated, all the way down until I get to those floating ribs or I don't feel like I'm feeling any movement anymore. Locate the rib angle that you want to look at, and then what you're going to do is through the arm, you are rotating the person's body anteriorly, and I'm assessing for how much does that rib angle come with me. If you're looking at the upper ribs, remember you find the spinous processes come out about 1 inch where the transverse process is going to be, and then what you're looking for is that head of the rib. You want to be on the rib itself, okay? You're going to cross your arms. So the pisiform is on the rib that I want to assess, okay? And then what this hand's gonna do on the opposite side is you are going to stabilize the thoracic spine. And then what you're gonna do from there is the assessment is in my left hand when I apply a anterior, slightly lateral and inferior direction, okay? And then I can go down, just assessing one rib at a time. So I'm assessing his left ribs. This hand is just trying to stabilize the thoracic spine from doing any type of a rotation. After I've done 2 or 3 there, then what you're gonna do is you're gonna come down to the side and again, stabilize the spine and just continue with your hypothenar eminence, your pisiform over the rib angles themselves, and you can get an assessment for how much rib mobility is going on there. Direction of my forearm, it's going slightly inferior, lateral, and anterior. It's kind of like all 3 directions. The left hand is just stabilizing. So what they say you can do is you can usually stabilize about 3 levels with your hand like that. So what I'm over is I'm over the transverse processes on the opposite side, so on Mark's right side. And all this is doing is trying to stabilize the spine and everything from moving so much, so I can lock that in and then I can get a good appreciation of how that rib moves on a stable thoracic spine. If not, then I'm pressing on the ribs, but everything's moving with me, so it's hard for me to tell how much is that rib moving in relation to the thoracic spine. The technique he's showing here is for someone who might have an upper thoracic mobility issue. They identified hypomobility, and now I want to do a mobilization for that. I'm going to stabilize T3. You're taking a pincer grip on T3. And then lifting the person's body up, you should get extension of all those above segments, trying to stabilize the bottom one from moving at all. T2 on T3 that I'm working on, okay? So if I want to mobilize T2 on T3 into extension, which vertebrae do I need to stabilize? T3. I'm going to stop T3 from moving, and then through the arms, extend T2 over T3, and then hold that position. If it's a mobilization technique, Kaltenborn grade 3, find the end range of the motion, I go into the plastic range of deformation, and I hold for 30 seconds to a minute. If you want to perform mobilization, right T2 into flexion, where should my thumb be placed? Right transverse process of T2. If I'm pressing on the right transverse process of T2, I'm getting extension, then there's extension of T1 on T2. Okay. And there's flexion of T2 on T3. The flexion technique is exactly the same as the extension technique, just pull them down into flexion. So if I was going to do lower thoracic flexion or extension, what we're going to have the person do is simply cross their arms over their chest like that. Come underneath their elbows with your hand, stabilize the segment, and I decide I want to do extension of T7 on T8. Where should my hand be? T8. I'm on T8, I'm in there with my pincer grip, and then I can extend him over that. I don't know if I would do this as an oscillation, because I'm lifting the whole body. I think I would reserve this one for when I'm mobilizing. If I want to do flexion of either of these, I'm just stabilizing and coming into flexion instead. If I'm doing this technique to improve mobility of T7 on T8 into flexion, where should my hand be? T8. Stabilizing T8. Where should my pincer grip, my stabilizing hand be? It should be on T8. Flexion up high would be the exact same thing. If I was interested of T3 on T4, I would stabilize T4. That's where my pincer grip would be. And I would bring him down forward. But for extension in the upper thoracic spine, so T1 through T4, they're going to be like this. I'm going to come underneath, and I'm going to lift. For flexion of T1 through T4, they're going to be like this. I'm just going to come over the top and let them come down. 5 down, then they're going to go to the arms crossed. Flexion, or I can do extension. You can convert anything that we've already done into the treatment technique itself, just by doing grade 1s or 2s, or changing it to a grade 3.